the next session, I would like to invite our respected chairpersons, Dr. Anil K., Dr. Mark Edward, and Dr. Greg Cousins. Can you please approach the dais, sir?
Thank you for joining us. We've got an interesting mix of advances in hand surgery, and in keeping with the way the meeting's run so far, I think we'll keep the questions to the end unless anyone's giving a particularly short talk. So I'd like to ask Dr. Shija, if they're here. Thank you very much, ma'am.
Good evening, respected seniors and my dear friends. So we are in the new era of medicine. So the question today is, can machines think? Well, this man, who is considered to be the father of artificial intelligence, Alan Turing, seemed to think so many decades ago. And this led to a number of science fantasy movies which we all watched as we grew up. So this image was created by ChatGPT with its DALL-E extension. And now we have come to a place where how do we differentiate whether something is designed by man or something which is designed by a machine. So there again, Turing is helping us with the Turing test. So how stupid a mistake can a human make, and how intelligent, more intelligent than human, can a machine perform? So that is the basis of Turing test now. And the successors of Turing have over the years developed a lot of applications of artificial intelligence, including the chatbots, starting with Eliza by Weisenberg, and now we have come to the era of ChatGPT. May I have a show of hands as how many of you are using ChatGPT? That's a very good number, so the rest have to catch up. There's no escape from this. This is how the ChatGPT interface looks like. So it is a highly popular chatbot developed by the company OpenAI. And this is the version 4, and you can see that there is a column where we can enter your commands, or which are called as the prompts. And by personalizing these prompts, now my ChatGPT knows me the way I answer, and that is leading to something called you have the option of developing a MyGPT even. And in version 4, you have a lot of plugins, and you can use all these plugins to create images. You can write a nice poem, or you can code even. So many applications are there. So I'm an artist, so I've used it to create images which are appropriate for this presentation. So I use two applications. One is DALL-E, an image maker. And for a more abstract image, I use the Cosmic Dream. And then based upon the commands that I had given, or the prompts that I had given, you can see that variants can be produced. I mean, something which much more than I can do. So the commands that we are giving is, that will decide the quality of the output that ChatGPT is going to give you also. And if you are having a logical sequence of the prompts, you can make ChatGPT think and behave like a human assistant. But this idea has already been used, and there's a nice paper which is coming up, how we can train it as a digital assistant. But our chairperson here has already, their institution is already using us in Singapore as digital assistant. If you look in the YouTube, you can see a lot of applications that they are putting this to in their center. So does the computer always have to be told what to do? Need not be. They are intelligent, and that is called as artificial intelligence. So let me define a few terms that you'll come across in this field. So what is machine learning? So machine learning is when the computer can use its experience and it can correct its own errors and create algorithms and outputs without the need for human dependence. So that is machine learning. And machine learning requires the access to a lot of data sets. It requires a lot of connectivity. So that is deep learning. And then the networks that are used for this are much similar to the neuronal network within the human brain. So based upon the levels of complication, there are different types of networks like artificial neural networks, convoluted networks, and so on. And the generative pre-trained transformer, like in ChatGPT, is a kind of network that is being used for the bot purposes. And as a consequence of all these activities, this generative AI is something which can now autonomously create new and original content. So based upon the kind of applications that you're using, you can create anything, images, voices, and so on. The simplest of this generative AI examples you might have seen when you saw your Gmail auto completing your emails. Now it is progressing with access to natural language processes, and large language model applications are coming in. And this involves a lot of data analytics. And Dr. Mahapatra here, and I've been a co-author for this, has published a big large language model sequence also. So apart from the bots, there are a lot of AI agents that are permeating different aspects of surgical management. So let us see AI, applications of AI in surgery. It is being used for preoperative planning, it is being used for intraoperative guidance, and of course, with different levels of automation, you can use it for robotics also. So AI has capability of transforming surgery from a labor-intensive process to a very data-intensive process. That means you need a lot of data and a lot of image. So because of this, probably, in endoscopy, this has made leaps and bounds. And with, like I said, with robots, yesterday we saw Dr. Raja Tiwari using a robot to do an Oberlin. But later on, without Dr. Raja Tiwari being there, by programming, the robot will be able to do the Oberlin in automation. So that's a level to which we'll be able to do the machine learning. So if you think I'm bluffing, probably you will think that I'm at the top here of this peak of inflated expectations. But just look at where endoscopy has reached. So it has gone now beyond to this enlargement and to the stage of productivity. So this is all possible. So endoscopy has progressed, whereas the other specialties progressed. If we take my specialty, plastic surgery, we see that we have not progressed much beyond this phase 3, which is up to checking the clinical therapeutic efficiency. And of this, mostly the work will be in craniofacial and aesthetic surgery fields, subspecialties, because we are image intensive. There's a lot of images that are available in these two subspecialties, and that is why AI is able to utilize these. It is being giving predictive modeling in microsurgery even. What about hand surgery? My subsequent speakers are going to speak about all these applications in hand surgery. Mostly it is for fracture detection, but there are several other applications also described. Does that mean that orthopedicians will be out of work soon? Hopefully not. But definitely it will help if it is increasing your specificity and sensitivity by AI applications. And if AI, instead of a 2D image like this, can give so much of data, why not use it to improve your clinical skills? You can use it for wound management and, of course, for predicting your surgical complications also. So all the risk scores traditionally available are considering the risk factor and the outcome in a linear fashion. But if you have these complicated neural networks, you can consider all the variables and have a more accurate prediction of what the outcome is going to be. So these are already available in app stores, the surgical risk calculators, which are AI based. We can use it for surgical analysis of operative videos. We can even use it for rehabilitation of patients with the use of coordinates, and some computer vision will be able to design programs to help your patients to do exercise postoperatively. Of course, you can use it for the automation and simulations and AR and VR for your surgical education. So there are a lot of advantages of AI in surgical field. But where is the catch? Of course, AI should be used with caution because there are some dangers also. Mostly this is the data privacy because you have to feed so much of data. It is capable of creating images like this, as you know, fake images with the for misintention. And this is a really big problem in plastic surgery, as you already know. Just like human brain, AI is also capable of hallucinations. This was something that Dali made for me some months back, and I'm still recovering from the shock of what this is. Because we don't know actually how it reaches the output from the input, and that is called the black box problem because it is opaque, and we will not be able to reproduce this. So there are a lot of ethical principles to be appreciated before you are into rampant use of AI. So what are the remedies? Yes, there are a lot of remedies possible, but the legal environment and ethical environment has to be strengthened. So what are the available things? Just 30 seconds. So one is regulatory and legal framework that is available internationally like the HIPAA and GDPR. HIPAA is in US. It puts out a lot of documents including patient consent forms as well as the employee non-disclosure agreement which you have to follow. GDPR is for European Union. General data protection regulation is there which we can use for our use also. And what about India? India is a fast-growing market which is growing at an exponential rate thanks to people like Mahabala sir. So the Niti Aayog has already launched the AI for All program. And in 2023, we have the Digital Personal Data Protection Act being enforced, which will be controlling most of this AI usage in India. And of course, AI has got a global presence as partner of many of these, so this can also be utilized. And for biomedical research using AI, ICMR has put on special guidelines. This is available in downloadable PDF format already. So before you entrust your patients to AI, let us ponder a few points. So AI is a tool to enhance, but it will never replace the expertise of the surgeon. So that is the optimism that I have, because it will take some more time for fine-tuning it and bringing all the regulations before we'll be able to do good use of AI in future. Thank you.
So, Dr. Vaikunthan was not able to make it due to some technical visa issues. So we have his recorded lecture right now about advancing hand surgery with AI, innovations and applications.
Hello, thank you for this invitation. I would like to talk about how we use an evidence-based approach in designing and developing a stroke hand clinic. Spasticity produces significant problems in the patient from pain, fatigue,
So still the AI is not taken over the scheduling of talks. Foxy has to come to spell that it's a wrong talk. I think the talk is scheduled for tomorrow actually. I can go.
In that case, I'd like to introduce Dr. Anil.
So this is a study we did on occult fractures in scaphoid detection using the AI. So when you look at the scaphoid fractures, the clinical problem basically is that missed scaphoids, almost up to 16% on X-rays. The classical teaching we know is, cast for about 10 days and then, repeat the X-rays. A lot of patients obviously would not want to wait. So we asked for the imaging techniques, which is basically the gold standard is MRI with the high sensitivity and specificity. So this is the problem with scaphoid occult fractures when they're not seen on X-rays and you need a diagnosis. with a good specificity and sensitivity. MRI costs, MRI has waiting times. So these algorithms from the AI derive rules and patterns from large amounts of data to calculate the probable variable outcomes. So that is what generally happens. This is the model, general model which is used. Basically what you put, you get the input and the output in terms of a lot of augmentation. So can AI help actually in fracture detection? So studies started off very early in orthopedics, at least, and then they said that yes, it is possible. They applied this for big fractures like intertrochanteric fractures to see whether any of these can be detected and clearly seen. So our hypothesis was, can an AI-based algorithm be beneficial alternative to MRI for early detection of occult scaphoid fractures on plain radiographs? And we didn't see any studies done on the Indian scenario. So the basic aim was to diagnose the occult fractures. The objective was to create AI and CNN-based algorithms for diagnosing occult fractures on X-rays. So we had first to do this between two groups. One is the fracture group and no fracture group. The machine had to learn what is a fracture and what is not a fracture. And then also evaluate between three groups later on, which is the occult fractures, the clear fractures, and the normal scaphoid using the CNN model. So this was a prospective study with the sample size of 525, normal scaphoids 250, clearly apparent scaphoid X-rays of 225, and suspected occult scaphoid fractures of about 50, which was clinically examined and proven by MRI. So this is the way it goes, the control cases and the scaphoid fractures. So we divide them into the training sets, the validation and the test set, and it goes through the data augmentation process and the deep learning, and then we evaluate their accuracy. The X-rays are cropped with respect to the region of interest, so we try to mimic what we routinely see every day on your PAC system or on X-rays, and which facilitates the network training by dealing with small values instead of large values. So you can crop the images into large region of interest or a very small region of interest so that you get the features of the scaphoid very nicely. And as I said, it goes through a process of the network architecture, training, and finally evaluation. So these are the values we had, the number of X-rays which went into training set, the validation test, and the test set in the 2 class, which was fracture and no fracture, and the 3 class, which was basically occult, fracture, and normal scaphoids. And if you look at the 2 class, that is between the fractures and no fractures, the sensitivity of 0.92 and 0.88 of specificity was what we got. And we looked at the 3 class classification, the overall performance, the weighted averaging when you took, it was 0.85 and 0.91, and the ROC curves of the proposed model for the 2, with both the 2 and the 3 class classifications also showed a good correlation between the false positive and the false negative. We also added another element of the graded weighted class activation map, basically highlights the areas where the occult fractures are through these CNN models. So one of the earliest in the literature where the AI-based algorithms were used for almost all these fractures showed that the AI model surpassed the humans in classification, especially of proximal and hip fractures. But for occult fractures like non-displaced neck fractures and scaphoid fractures, it is yet to be established, and that's why we took up this study. So you look at the data sets, of course, the data sets are small. We don't have a registry system in India to pull out large data. The more important thing is, again, the occult fractures. A lot of documentation is not there. We have an occult fracture, MRI proven, right? So that is where we lack. But otherwise, we use the full range, region of interest, which is what we normally see when patient comes with an X-ray or we take an X-ray or see in the PAC system. So the full region of interest is what is actually clinically mimicking, and that's why we chose that particular model, and that shows a good sensitivity and specificity and the area under curve values. And it kind of matches with the largest studies what you see there. So our proposed model is able to achieve high performance result using the full ROI images, but other studies do go to the external, an additional step of segmenting them into small ROI, and it did achieve high sensitivity as compared to the previous work. And for the 3 class classification, especially with the occult fractures, it also had a very, very good result in terms of the data sets. The 500 data sets is still not enough. It requires external validity. It requires multicentric kind of data pooling. And that is very, very important for us to say, yes, this works. And it included two plane radiographs, the PA and the lateral. Sometimes people might ask, you need to take the entire scaphoid series for this for you to really tell whether it works or not. Okay, and this is what we published in the last year, where the same study was published in this particular journal. So the misdiagnosis is a serious problem that has plagued emergency departments for several years, and the addition of clinical decision support tool like the AI in scaphoid fracture detection definitely reduces the misdiagnosis and the subsequent complications. Thank you so much.
I think we've got time for questions if there's any questions from the audience. So Anil, are you currently using this in your clinic?
Not yet. Not yet. So we need external validation. That is what's first thing. We would really want to augment the data with more data sets before we actually can make it as a product to incorporate into our PAC system. That's very crucial for us.
Okay, thank you. I think the video is now available, so we'll have Dr. Vaikuntan's talk online.
Hello, good morning. It's a great honor to be here. In this lecture, I'm going to talk about some use cases of how I use generative AI in my daily clinical practice. I hope you find this useful. I'm sure everybody is aware about generative AI, ChatGPT, Gemini, and Copilot. They are here to stay. AI will not replace you, but somebody who knows AI is going to replace you. So what is generative AI? Generative AI is just a computer that attempts to think, in inverted commas, as a human using the predictive modeling based on large language model. That means a large amount of data has been collected, and based on your prompts, that is what you ask it, it used the prediction of what should come next in the form of a generated text. That basically is generative AI. Today we have conversational AI, especially with OpenAI's new conversational tool. This is fantastic, and you will see some use case as we go through this lecture. Its application in hand surgery is immense, from clinical to research to education. Remember, it is not a human. So these are the various functionalities and how you could use generative AI in your practice, in creating new content, in analyzing medical images and clinical photographs to help you make some decisions. You can summarize patient records. It is very important that you understand what are the ethical issues, like hallucinations. Is sometimes it gives you false data and false results. You need to be able to validate that as you are a subject matter expert. The content validation is crucial, and its use must be ethical. It can impact research and the creation of synthetic data. We are currently working on a chatbot using various validated questionnaires to diagnose carpal tunnel as a screening procedure. You can create your own chatbot, your own intelligence systems to support you in decision making and even in helping you to educate patients and create educational material. In terms of our various points, the pain points that we have in hand surgery, from recording medical records, clinical encounters, writing operative notes, informed consent, generative AI can help you. One of the important steps in how to get the best out of generative AI is prompt engineering. Prompt engineering, it just means how do you write questions and instructions to this generative AI model to get outputs that are good for you, that meets your purpose. And here is the various steps: defining your objective, understand which model you're using, break down a complex task into simple tasks, create clear and concise prompts, and then start. You can use few shot prompting, many shot prompting, or zero shot prompting, which is you can give it examples of what kind of answers you want, and then you need to look at the response, refine it, validate it, and if need be, re-prompt till you get a satisfactory outcome. The most important element in prompt engineering in use of generative AI is the validation of the outcome. It is important you as a subject matter expert understand the prompt. Does it make sense? Remember, it can hallucinate and give you false data. You are responsible for the response that you get from generative AI, and when you use it or publish it, you take responsibility. For us in the clinical environment, the best version to download onto your device, your mobile device, is the ChatGPT for Android or for iPhone. It's up to you, whichever you use. Please choose the right app to download. There are a lot of fake apps. Be aware of that. Next is the use of AI in our clinic. Here's an example where I have uploaded an image. This was a couple of months ago. We had a patient who came in with this injury. I put in the brief detail. We are very familiar with that, and ask it about its management. So this is only available in the paid version where you're able to upload images, documents, and PDF. Here's the response that I got. It gives a very good initial assessment. It's pretty accurate. I feel that it is good. And then as I prompt it a little bit more, it gives me some surgical considerations, tendon repair, bone injury, and skin coverage. And when asked for skin coverage options, these were the recommendations from a cross-finger flap, reverse radial forearm flap, which may be a bit much for this. But when I pushed it for something better, and I got a heterodigital island flap, which could be one of the options. And when I asked it what would be the best for this, and this is what you got. So the heterodigital island flap was a solution which you may agree or you may not agree. What about operative notes? Now we are dependent on our registrars to write, but the accuracy may not be useful. Here's an example where I created an operative note assistant for me. This is my personalized chatbot. You can use it if you want to. The QR code is available. And what it does, it provides a detailed and precise operative note on a very brief prompt. And if you can see in red, basically I just said I did a right carpal tunnel decompression, 5 mils of lignocaine and was injected, standard carpal tunnel decompression, but I also added there's an hourglass deformity noted and a neurolysis was performed. And this is the detailed notes that has come up. The neurolysis was there, the closure, everything is done proper, and this is very useful, done in seconds. You can email this to your, or you message this to your registrar to write up the notes. The other area of interest is the EMR assistant, and this is my big pain point. We are a paperless hospital, and if you download the mobile app onto your phone, you could use that as a clinical recording device, an ambient clinical record, and this is what I have created. It's called the EMR assistant. You're free to use it. By the way, all these personalized GP require a paid account. Once you have downloaded the app onto your phone, you then switch on your phone and clinically record your encounter with your patient. The full video of this demonstration is available on this QR code. So what it does is, in the first initial step, it takes your recording and transcribes it. This is done automatically, and you can use it in various languages. Not all languages are supported. It supports in Chinese, it supports in Bahasa Malaysia, it supports in Tamil, but I think you need to play with it. And once the transcription is done, you're ready for the EMR. As you can see here, it's automatically generated an EMR, electronic medical record, which you can then cut and paste into your hospital system. It also then gives you a brief clinical synopsis, a summary of what occurred at that clinical encounter, and this is very useful. We've just updated the app to include ICD diagnosis and a treatment plan. And this is another chatbot that I've created for teaching basic hand surgery, and it's again available, especially very useful for training residents, and even be used as assessing them with scenarios and with viva sessions. These are all the very exciting things that you could use with generative AI. And you can find a summary of what generative AI can impact hand surgery in this paper that we published, and you may find this useful as a resource. However, we conduct one-day workshops for healthcare professionals on how to use generative AI. This whole workshop is available for you, as an online module at this place. And for those who want more information, I'm very happy to take questions and discuss how we could collaborate to integrate generative AI into your practice and make it worth your while. I hope you enjoyed this. Use generative AI and outperform yourself. Good luck and thank you.
Okay, thank you. We'll now move on to our next speaker, Dr. Stefan Schindele, who will be speaking to us on planning 3D corrective osteotomy techniques and considerations.
Dear chairs, dear colleagues, thank you very much. Now we change from AI to software developed technique. So usually you do corrective osteotomy in the forearm or in the hand. Usually you do that freehand, but some years we know that we have other techniques. So these are the conflict of interest. If you go online, then you will see there are several systems available for 3D planning for correction osteotomy in hand surgery. First, it started in the maxillofacial field, and when you all look at this, then you will find several software techniques where they can plan your malunion and you can get guides. And there is one company, she can also print plates which are specially made for you. So the difference is same, some by playing by your own and with the knowledge of the software, and some planning with a technician. All you get printed guides, and few you get printed plates, specific plates. You see that afterwards. So first we get in contact with a company in 2015 with the individual patient solution. They used that for the maxillofacial field, as I said before. And these are really printed plates. We are made by a titanium printer. You see this by a titanium printer is a big one, and I know also a very expensive one. And what you get afterwards, after planning and printing, you see those plates, printed implants, and they are adopted to the individual anatomy, and you can have them how you want to have that. On the right side, you see why should the plate always be straight. You can do that also curved or angled. That depends a little bit on your choice and also on the fracture pattern or on the malunion pattern you have after the correction. You see that these are several plates we used in our clinic in different patients, and all of them are individual. Also, you can see on the plate that there is the name of the patient and also the number of the patient printed on. So it's really individual. Now I want to show you our way how we perform the planning with this individual patient's system solution. So first we analyze the malunion. So on the left hand you see that there is a distal radius fracture with this malunion, and then we do X-ray from the contralateral side, and then we compare that together, and then we discuss the further planning with the patient. Should we correct that? Is there any problem on this wrist? And if the patient says yes, then we do a CT scan of both wrists according to a special protocol, and usually we started only for the wrist, and now usually we do that for the whole forearm. So also this is for the patient not a real problem. Then we get the data from our X-ray department, and then we send it to the IPS gate. You get that online. You will find that for phones. You find it for mobiles. Find that also for PCs. You send that here, and then you make a web meeting with a specialized technician. And you can see on the right side, this is the technician with a special tool where he has uploaded the data and made it 3D, and you're on the left side, and you can do that from the one end to the other end of the world. Then you get that. You will see that on the left hand, you see the blue one is the healthy one. It's mirrored on between, and the gray one is the malunited bone. You see that it's very short, and you can turn that, and you can precise a plan where should your correction be, or your plane where you have to make the osteotomy. And there on the right, you can see that. And then you can move. You said, "Yet I want to have that." And then you move the distal fragment on this distal radius in the correct way, where it has to be from the contralateral side. And then you go a step further. Then you see on this video, then you have an idea how much you have to correct. You can measure that, you can have a look, and you can have a look what the size of wedge you need if you want to do a grafting. You can also have a look in the DRUJ, you can see the sigmoid notch, and then you can plan also the plate, which is really individual, and you can plate that, or you can plan that together with the technician. After a preparation time of 1 or 2 weeks, then you get a planning report. You see that here. The blue one is the malunited side, and the health blue one is the healthy side. And then you can see how much you have to correct. That is comparable to the contralateral side. And then you get a suggestion for the guide and for the implant. And here you can see this is a plastic guide. It's also printed in a 3D printer. And there the technician made the guide for you with the holes and the sliding slot for the plate. And there you can see on the right side, you can see the malunited bone and the corrected bone. You get also an idea of the wedge and the printed implant. Then here you can see how it looks like if that should work. Also you get a report about the length of the screws. Then you get, after confirmation, a 3D model. It's the guide with malunion, with correction and bone grafting. This is the plate. Then you go in the operation theater, you perform the operation with the guide. It's a standard typical approach to the radius. And then you do first drill the screw holes, then you do a secondary, the osteotomy, then you have done the osteotomy, and then you do fixation of the plate distally, and afterwards secondary. Usually you need also to get a little bit lengthening, as you know that from the freehand technique, and then it's done. So in this young guy we had to correct a lot, and that's why we used here a bone graft, and this is 14 months after removal of the plate. You can do that also in forearm malunions, and I think in forearm malunions it's mandatory, because very often you have a rotational deformity, and the rotational deformity you can't correct freehand. This is very, very important, especially if you have to correct two bones. We did that also on metacarpal malunions with this system. Yeah, you can discuss if this is necessary, but if you once are pleased with this system, then you want to do more and more. We published that 2022 in the American Journal of Hand Surgery, and our first 15 cases all were done. So the operation time was in the beginning a little bit longer. The patient outcome measures were fine. Also, range of motion was better than preoperatively. So 3D planning in corrective osteopathy is a young digital technique. We have necessary tools. We need a CT scan for both sides, the malunited and the healthy side. Then the technician needs knowledge of the software. And then you get patient-specific implants, which they fits well to the individual anatomy, and necessary in rotational deformity, especially if you have two bones in the forearm to correct. Thank you very much.
I think in view of keeping to time, I'd ask Professor Bain if he would come and talk more about the physical side of training rather than using AI models.
Great, thank you very much, Greg. Thank you for the invitation. It's been a wonderful meeting. I'm really quite impressed. Well, we're very impressed with the quality of the entire meeting, the organisation, and so many topics covered. I'm going to talk about advanced manufacturing surgical training models, which is something that I've been involved with the development in Adelaide. I do have a conflict of interest with this presentation. So I think we all learnt in the traditional way of how to manage surgery, and we all got a license to operate, but we probably weren't trained. And I think that's something that remains a problem, and particularly when we get into more sophisticated surgical procedures, arthroscopy and advanced arthroplasty, that I think we need to be looking at other ways. The model that I have here, same as the image on the top left, this is the CT scan and X-rays of the actual model and fluoroscopy of the model. We can see a 3D CT scan of the model. Being a bit of a wrist guy, I made sure that all the ligaments are right so that they're all in the correct position so that we can recreate the instabilities. This is a course I was involved with running, and what we were able to do is the model, we've got a displaced fracture, and the challenge for the doctor is to be able to assess the imaging, to be able to identify the fracture, reduce it, and then stabilise it. So you can see he's been able to put the plate in reasonably well. He's obviously a very quick surgeon. And there's the final position. Unfortunately, he didn't reduce the fracture, which sort of might happen in your hospital. It certainly happens in mine. So although he was very good at all the other things, the one thing the model's designed to do, because it's specifically pathology on demand, has a fracture with displacement, we were able to test his ability to be able to do that. We're also able to do some of the other surgical procedures. In the interest of time, I won't go through those, but we can make an arthrotomy down the back, release all the associated soft tissues to identify the carpa. So all the fundamentals of surgical exposure can be taught. And this is the scaphoid component. So the model has a distal radius fracture. It also has a scaphoid fracture, scapholunate instability and TFC tear. So you can see some of the examples of the involvement of the scaphoid fracture. And because the way the bone works, we're able to put screws and plates in there. We can use the fluoroscopy. So it's able to reproduce the surgical challenge, including how you should appropriately perform the fluoroscopy so that you've got a good reduction. Going on to arthroscopy now. So this is in a dry lab that the FuseTech have set up in Adelaide. It's a 25-bed lab. So you can see here the scaphoid and the lunate going through the capitate. So it's got a drive-through sign for the scapholunate stability. You can see the fracture of the distal radius there. We come up through the mid-carpal joint. And we can go across to the ulnar side of the mid-carpal joint as well. This is with the nanoscope. Basically just it's a different sort of scope. We can see down between the scaphoid and the lunate, and you can see down to the distal radius fracture. We're able to manipulate that and open it up. But more importantly, we're able to practice reducing it and stabilising it. So we can see here we're just using gloves. You don't need to wear gloves. I try to do it all dry. From our local hardware store, I got this nice little power drill for under $100. I thought was pretty good. And we basically can create the same situation, also going on to triangular fibrocartilage tears. So we've got a tear of the triangular fibrocartilage here. We're able to practice or be able to perform the standard techniques. This is Toshi performing a DRUJ arthroscopy. I must admit I was a bit nervous at this point because I hadn't actually put the scope in there, but it actually looks pretty well reproduced the anatomy, and Toshi seemed to think so as well. Also, the one thing I think is very useful is all the little TFC repairs and scapholunate ligament repairs, which are technically challenging to be able to perform them on the model in a safe way without restraints of time, the fluid, or even worried about the safety for the patient. So we can make a small arthrotomy and go ahead and stabilise that. This is just a different way of performing the repair. So basically all the fundamentals, or if you wanted to do an open repair, you can do an open repair and debride the TFC, put a suture anchor in and stabilise that into position. And then all the other components that need to be stabilised. This is a Motec wrist replacement. I'm not sure if you have them here, but this demonstrates how we can use the model for the Motec arthroplasty. So this is an important thing to be able to do. So if the first time you're doing it, you really want to have the opportunity to do it on something like a model or a cadaver. But the advantage of this is you can actually have it in this room here today. Going on to the thumb, there's a number of surgical procedures that can be performed. So this is the new touch prosthesis that's just become recently available in Australia. I'm not sure if you have it here, but basically the fundamentals of how to do it, the oscillating saw, and all the little brooches and things. So this is, before I did my first case, I did 2 of these so that I could hopefully learn how to safely do the procedure. So from a training point of view, I think it's actually very good for that. So there's doing intramedullary screws. There's our chairman showing how to put the field screws in, and so that's able to stabilise it. But you can also use these models for fractures, so that we basically designed it to reproduce what you may do on an AO course. And I don't do much in the way of ultrasound guided surgery, but this gentleman does. He's actually an expert at it, and you can see there he's actually able to, on the model, reproduce the technique of performing an ultrasound guided carpal tunnel release. What I really want to do is get the chairman in the room, give them this complex case, a complex perilunate, get everyone to do it together, and so we learn how each other does it. So the models currently as they are, I think they're fit for purpose. We have pathology on demand. Stefan just gave a beautiful talk on how to use for distal radius malunions, so that could be made. Also all the arthroscopic things. So the future of surgical training is to do it at any time, anywhere, to take the teaching to the doctor instead of flying everyone to a city. Thank you very much. And you can do your own home scope as well.
Do you have any questions for Dr. Bean?
Greg had one.
I'm entirely familiar and very impressed with this system.
If not, thank you very much. And
Thank you.
I guess it's now time, my pleasure to invite my co-chair to give his talk on using AI for transcribing consulting.
So nothing sophisticated here. You've already heard some very sophisticated talks and a wonderful introduction to AI. I'm not entirely familiar with this. I have a teenage daughter who does all my AI and sets up the iPhone for me. AI will replace all our dictating. There's no question about that. I've been using this system for 6 months, and it's probably the best thing since cannulated screws. Clearly, the best part of our day is not getting home to our office, or when we get home on Monday after this conference, we're faced by a pile of charts. And essentially, what this does is remove the need to do any dictating, or very little dictating. And if you're anything like me, you became a surgeon because you like operating, not because you like dictating reports to insurance companies. One of the things I've noticed about it, if you've ever used like Dragon Dictate or the previous voice-to-text programs, is they're very susceptible to ambient noise. This has some incredible background processing going on. I can use it on my iPhone in a crowded room, and the background noise doesn't seem to phase it at all. From the point of view of using ChatGPT, we wouldn't be allowed to use it in Australia because it doesn't meet the safety requirements in terms of data breaches. However, this particular program that I use does. They apparently set it up consulting with medical defence organisations and also the government. So it's something that we can just sign up to and subscribe to now. I'm not sure, as you heard, legislation is very slow to keep up with technology, particularly medical technology. So it's used for generating the actual notes, but then from the notes, the AI will produce the GP letters, medico-legal reports, work cover reports, insurance letters, and what it's really good at is doing referrals to other specialties. You just tell it what specialty you want to refer the patient to, and it will pick out from your consultation the appropriate details. I don't think I'll spend too much time. This is just how you use the program. It's got the recording side and then a notepad that you can enter text into at the same time. So if the patient's in your office and they're still wearing sunglasses, or they bring their arm on a flowery pillow and they're not using it, you can make these sort of comments and note all the red flags. Through the top, you just put whether it's in person, telehealth or phone. And then this is just an example of what it's prompted to listen to. And as you can read through that, you can see this is a difficult patient, it's a work cover patient, and the predominant issue, he has a prior history of mental health issues and dependency. And so when you stop listening, you can ask it to write a document. You can see you get default images, default templates, and then ones that you can use and make up yourself. And we heard about the prompting. It's just a matter of prompting, assessing, and then reprompting, and you can get it to make pretty much anything. This is the letter that the AI comes up with for the patient. As you can see, it's, if you know me anyway, it's far more caring than I would come up to. It's supposed to mimic the letters that I would write, but you can see that I'm very concerned about his mental health, and I'm going to write to his GP. But if you prompt it for all the things you want to appear in your notes, then they will appear there. The difficult thing is when you start is it's not going to know what you want to record, and you could spend 5 minutes describing the x-rays, but if you haven't told it to listen to your findings on x-ray, it's not going to record any of that. You can see there it's able to come up with all the things that the insurer wants to know about, including the prognosis. So the AI has determined that prognosis. I didn't actually mention that, but the AI has determined that the prognosis is guarded. So the template's the interesting thing. You can make your own, and then you can just keep re-templating once you've seen the output. The letters, again, it can be as brief or as verbose as you want them to be for the GPs. It does have the capacity to use macros. I don't use them. I think you could certainly use them for standardised forms. We do, I guess we do to some extent use them for our post-operative notes, and but I don't think there's a place for having them insert the fact that you discuss the risks of surgery with the patient. I think you need to actually sit there and discuss those risks with the patient. And when you have a difficult patient and you've spent half an hour with them and you look down and you've written like 2 lines and nothing else and you're running behind, that's when this program is just fantastic, because it's listened to everything you've said. It's listened to the fact the patient's concerned about things, about returning to work, all sorts of things, and it records all of those things for you. So from a medico-legal point of view and a defence point of view, I think it's absolutely fantastic. The other thing is it learns to deal with the Australian accent, and you just replace as you go along. The interesting thing about the large language models is that they think all of them translate your native language into English, then produce an answer and then translate it back into your native language. And even if it's translating from Russian to French, it'll go from Russian to English, back to Russian, back to English, back to French. So there may be some problems with the Indian language models. Example letter from a GP. You can see there, this is a patient that had a plate, distal radius plating, and then had later had an ulnar shortening, and you can see that the AI is not smart enough to realise that we're talking about 2 different operations and 2 different plates, so you have to be careful and go back and edit. And that's the insurance letter that generated. So thank you very much.
We have 5 minutes for questions.
Great. Can you put your old templates that you might have had before into that system? Can you take your other templates, just download them into it?
From what? Templates that exist in...
Templates that you might have had from operation notes or...
Oh, absolutely. You just type them in. It's just a text-based field, and you tend to listen for description of whatever.
Can I ask a question?
Sure.
Do you inform the patient that you're recording the...
Absolutely, you have to. I didn't show you the box, but after you've entered all the demographic data in, it flashes up a box that says, have you discussed the use of AI with this patient? If you click no, it just takes you back to the beginning. And when, I think we probably all have our patients sign consent forms and privacy forms when they come in to see us, so we've simply added another form that company gave us, indicating a little, like 5 points about the fact that the data's not stored, it's encrypted, and so this is not added to the electronic medical record. You have to cut and paste this and put it into your EMR. And that's, one of the major problems with AI is it doesn't have any memory, so what you did with ChatGPT today if you do the same thing tomorrow, it's going to give you the same answer. It doesn't know what it did yesterday. And so the same thing with your consultation. So you have to keep going back and saying, oh, you're now 6 weeks post-distal radius fracture, or you're 3 months post-distal radius fracture.
So as the journals now tell us to declare your AI, the role of AI in your manuscript, or how much you've used it, so does the insurance companies do that now with the AI-generated insurance letters? And
I haven't been told that, but the medical, one of the medical defence organisations said it's important that you
declare that.
well, just that it was transcribed using AI. So that's just at the end of the report. But literally, it turns a 1 hour medico-legal examination into just the 1 hour medico-legal consultation and maybe a 5-minute review of the document. You don't have to spend another hour dictating everything.
Any other questions from the audience? Yeah.
Have you had a discussion with the professional indemnity providers about this? So, with the medical defense organization?
Yes. Yeah, absolutely. They think it's wonderful. Like if you talk to a solicitor after someone's made a complaint about you, the one thing they want to see is your notes. And if you've documented it, and this is what it does, it'll catch you out there. If you haven't discussed it with the patient, it'll be clearly there. You know, no risks were discussed with the patient. But if you do, if you spent 5 minutes of that 15-minute consultation explaining to them the surgery, the techniques, expected outcome, possible complications, alternatives, all those things, it will document all of that. It doesn't make you indestructible, but the solicitors absolutely love that. As I say, bad note, bad defence, no notes, no defence.
Any more questions? Yeah.
So the encryption in the data, it can't be removed until there is a litigation. So that is, it won't go to the company which has the software.
No, it doesn't. It's never kept. They don't have the data. So the actual recording, there's no actual recording of the consultation. There's only the record of the transcription. So that's, and the encryption is at their end, and it's kept on the cloud for you can, I think it's 7 days, but you can keep it for up to 3 months. And that's useful mainly for creating an insurance record if you've seen the patient 3 times, and you can then use each of those to create the insurance document.
Thanks.
Dr. Bain, your models, is there any way we can make it available to a large number of trainers at a very cost-effective way? Because once it's used, can be used reusable in any way, or?
If I contact the people who make it, I'm sure they'll be very happy to provide them for you for a large number of people.
Yeah.
With regard to the reusability, so there's sort of like different sectors. So you have like the main sector might be, say, the wrist that you're operating on, so that would maybe like a single or twice use, and the other parts may be multiple use. In the shoulder, I do quite a lot of shoulder surgery as well, so I've been able to have a rotator cuff tear, which we repair, and when you repair it tends to make a little bit of a hole where the sutures go, so I've been able to super glue that back together, so I've been quite pleased about that, so I've been able to get 3 repairs out of a rotator cuff.
Thank you.
Very Indian style. Professor Joshi would be very impressed.
Yeah, I was just thinking about that, how to make it useful for the Indian scenario. Yeah. Dr. Reddy, you had a question? Yeah.
This ChatGPT is usually one way. You prompt and then it gives the reply. Of late, it is starting conversation on its own. It's just experimented, just put it back again. So that's going to give us a lot of misinformation and try to brainwash us in getting to understand what it wants rather than what we want from it. So do you ever experience, that's why I open my chat box, wait for 5 minutes to see whether it's going to prompt me to say something, and if it doesn't say anything, then I start my conversation. It's, for a few of my friends, it started prompting and then it took it in a different direction. He also got confused and got lost into the...
It's a pre-hallucination stage, I think. Dr. Shija, you want to take that?
There are some pre-recorded links, I think. In ChatGPT, you see some connections where you can ask for the latest fashion advice or something. Even maybe because it personalizes and based upon, I think over the use of many months, it knows the things which you're interested in, including the extracurricular activities. So it asks about the books that I want to read, something like that. But the problem happens only if you're clicking on that. If you're not, I think.
I guess it's just feeling lonely and then it just wants to. The previous login and this login, if you had a long time, I think it just starts off.
Okay, thank you for the great presentations and discussion. I'm quite sure this will be a rapidly expanding field that we'll discuss a lot more about. So thank you very much to all the speakers, and we will close this session.